of the most common presenting feature is of the muscle weakness. Said earlier that this is symmetrical. Proximal muscle weakness, evolving over weeks to months, is the presenting symptoms in most of these patients out there. So, of these proximal muscle groups, we are talking about the neck, pelvic, thigh, shoulder muscles with symmetric again. Hip flexors are the most common affected leg of a muscle, so it's out there. The low muscle endurance, this is of the difficulty of repetitive movements more than of the single strength exercise. So they've got some of the difficulty walking uphill or upstairs, working with the arms above the shoulders, rising from the chairs, so standing up. They'll have gradual onset with progression. The distal weakness should occur only in the presence of proximal muscle weakness. So if they're not having any of the weakness proximally, then we can reconsider what the differential diagnosis is, because these things are of the proximal. Key slide. Clinical findings. So arthralgia, myalgia, frank arthritis, severe fatigue, and the Raynaud phenomenon may also be present. They can also have some of that dyspnea, and it's because of their diaphragm or, matic could have some of the weakness. So it's hard for them to breathe in and out. Now, earlier, I talked about the cutaneous. I talked about dermatomyositis only. There's 3 things out there, and all of them are pathognomonic. So you've got those of the Gatron's papules, raised violaceous lesions on the extensor surfaces. Most common, we see these on those of the hands. So MCP, PIP, DIP. It's not listed, but the IP of the thumb could also be out there. So that's one of the 3. Second one is of a Gatron's sign. So you've got erythematous rash involving extensor surfaces. So from a dermatological aspect, which I like derm more, the heliotrope rash, pathognomonic, red or purplish discoloration of the eyelids. This may appear as hyperpigmentation of the dark-skinned people out there. So one of those 3 you will see. Less specific rashes. You can also have of a Shaw sign. You can have of a V sign. You can have some of those hikers' feet, mechanic hands. So the Shaw sign, y'all know, it's like they have a shawl on, right? So it's on the posterior neck end of the shoulder. V sign is that rash on of the anterior neck and of the shoulder. So it's the V sign. And then you got some of the hyperkeratotic skin thickening on radial surfaces of the fingers, toes. It can hurt, but look at those pictures out there. Heliotrope rash. So you've got some of that reddish to purple eruption. Heliotrope rash, again, it would be similar to of lupus, but this one usually does not spare those of the nasolabial folds. So it's all over, whereas lupus misses those spots. Another a pathognomonic are of the Gatron's things. So you've got those of the papules as seen on of the joints, right? Over there on of the left, you can definitely see MCPs, DIPs, PIPs. They're all over there. There's that V sign and that Shaw sign. These are those less things than those other 3 pathognomonic ones. Mechanics hands, more of those areas. Extensor areas. This young man has that V sign as well. All right, so the diagnostic and evaluation. Major diagnostic is that of a muscle biopsy. So we want to get into those proximal muscles, which we suspect, and get those the biopsies out there. We also want to look at those labs. We already talked about the CK, AST, ALT, but we can also check Adelase, LDH, okay. These things are not all of the same. That will show you where they're at, which of that stage of disease course. We can also see that abnormal of an EMG that will put it out there. Again, the diagnostic are those rashes that we spoke about, the dermatomyositis ones out there. We can also be looking into those of the other things. So of the anti-Jo1 antibodies, 20-30% of those will have those, most likely in of the patients with interstitial lung disease, so that ILD, which we talked about. Also some of that Raynaud's, non-erosive arthritis, mechanic hands, so they have that anti-synthetase syndrome. ANA, we know that that's elevated on everybody, okay, so that's in here. We can do malignancy evaluation, so we're going to have that on the symptom-based evaluation. We also want to look into the age of the gender appropriate of those screening. Reasonable evaluation includes of the detailed H&P, those labs which we talked about but added in that of a GGT is usually released along with AST and ALT in the liver disease, but not from of the damaged muscle. We talked about that of an EMG, right? We can also send them out for of an MRI so that we can evaluate for edema. You know, they're having some of that active inflammation or of the fatty infiltration. Helps determine site for of that muscle biopsy. So where are we going to poke that at? When we're doing that the muscle biopsy, all of the patients in whom autoimmune myopathy is suspected, that's who we want to do that into. If we're going to do that, we want to do of the deltoid or of the biceps. That's a good spot where we got a lot of meat, right? So we can get some of that out. Inflammatory muscle disease treatment, okay? The goals of the therapy are to include increasing muscle strength. So let's make them swole. We want to control that of the pain. We want to enable them to manage all of their activities of the daily living, as well as improving their quality of life. So let them go out and have fun. Mainstay of the therapy focus on control of inflammation through immunosuppression for specifically dermatomyositis. Should get a shot for every time I say that word. Corticosteroids. The first line is prednisone 1 to 2 milligrams kg day for 3 to 4 weeks, and then we're going to taper it off. So if it is dermatomyositis, that first line is of the prednisone. We will sometimes have to prolong that. We'll have to do it frequently and then do that high dose of the tapers. Side effects include steroid-induced myopathy, poor functional status at the diagnosis may warrant second-line therapy. And what are those things that we're going to have to get into some of that immunosuppressants? Well, if the patients are experiencing the complications from long-term of the prednisone, the glucocorticoid use, we have the inability to taper that steroid dose without precipitating a myositis flare. It hasn't been working for 2 to 3 months, then we need to get into immunosuppressants. Or last one, if they are rapidly progressive disease with respiratory failure. All right, some other treatments once we get into those of the steroid sparing agents. Azathioprine, so that's AZA, improves serum CK levels when compared to those using prednisone alone. Can a pregnant use AZA?
Yes.
Methotrexate used with caution may cause the pneumonitis, may appear as the patient is having some of that ILD. MMF, some benefits of the dermatomyositis, but can MMF be given to a pregnant woman? Why am I bringing up stuff from yesterday? I don't know. You also have the other ones out there. So rituximab, IVIG, cyclophosphamide. Again, we're using those with that ILD and regular exercise. Get them to the gym. Very poor prognosis if associated with underlying malignancy. So they're having some of those other things that is feeding into what of the muscle weakness is. Otherwise, dependent on severity of the muscle weakness, which is just what I said, extra muscular involvement and their response to the therapy. They can also move into some of the endo stuff, so the Cushing, opportunistic pulmonary infections from long-term steroid use, P. Girochi pneumonia. Do we have any questions about that inflammatory things out there? I guess not. But a lot was said. It's not a lot, because it doesn't need to be a lot. But what y'all will see was said. So now we're going to talk about vasculitis. Vesiculitis, also known as that polyarthritis nodosa. Just like what we just spoke about, it is heterogeneous group of systemic disorders. They are all characterized by inflammatory destruction of the blood vessels. So we've got inflamed blood vessels that are liable to occlude or rupture or develop of a thrombosis. So this is the reason why we want to prevent that progression on. Degree of these manifestations, highly variable based on the vessels and the organs that are involved, because this is not going to be all head to toe. It'll have some of the locations that's their specific where they want to go. Primary vasculitis is the most common classification is by the size of the blood vessel involved. So we can have that be large, medium, small. That size can overlap, so it could be half medium and half large. Secondary vasculitis, then we're looking into some of those things that we have already spoke about. So rheumatoid arthritis vasculitis, lupus associated vasculitis, and IBD can also be in those things out there. Epidemiology wise, 1 in 2,000 adults have some form of vesiculitis. 1 in 7K develops vasculitis annually. The most common forms of primary vasculitis. Number one is what's up top, GCA, giant cell arteritis, and we're going to get into that later and talk about it. We can have what used to be called Wegener granulomatosis, but now it's just got that definition as its name because it does have involved some of that polyangelitis. And then you can have microscopic polyanginitis. Yeah, JITS. Classifications, so it's that diagnostically challenging. Other considerations for the classification besides blood of that size is of the demographics. So what is the age? What is the gender? What is of ethnicity? What are of the organs involved? What's their pattern? Specific pathology. So is this immune of a complex deposition? Granulomatous inflammation? Is it associated with some of the antibodies? Are we having infectious associations? So Hep B, C. Breaking it down, we're going to talk about the large of the vessels. So we've got those of the names. Takayasu arteritis, GCA. So that's that one that was up on top over there, which we're going to speak about. The Behçet disease, that is, could be not only of the large, but it can get into of the medium and small. This is a variable vessel disorder. And then lastly, over of the large things is that T-cell mediated antigen driven of the pathophysiology. Medium wise, now we have the polyarteritis nodosa. Burgers, like it said, it can be small and medium also, can see that, but it's called of the thromboangiitis obliterans, and then Kawasaki disease, mucocutaneous lymph node syndrome. So that's the name of it. Some of y'all will remember that because we talked about that in the past. Small of the vessels, so we've got immune complex mediated vasculitis. Cutaneous is what it can be, so that's that hypersensitive vasculitis. It can also be Henoch-Schönlein-Purpura or cryobulinemia. ANCA associated is granulomatosis with the polyangiitis, which we saw with the large. That's what it used to be called, was the Wegener's. Eosinophilic granulomas with, so it's the same thing, but adding some of that eosinophilic. And then we can see that of the microscopic polyangiitis there. Etiological wise, it's generally unknown because it could be any type of vesiculitis. So those things could be immune mediated factors, so antibody associations, immune system activation. So we see those two that are sitting right there. Specifically, some of genetics and ethnicity talked about the Behçet's, which can be on of the large, medium, and small. That's of Turkey. Kawasaki, Japan. We can have some environmental factors that are the etiology of here. So we can have smoking and of that thromboangiitis obliterans. Can also be some type of infection. So we can see the bulimia and hepatitis C, but also the polyarteritis nodosa, which we will look at in a little bit, hepatitis B and C. So the clinical features, when to consider of the diagnosis. Well, if they're having some type of a multi-system disease, they have some of constitutional symptoms prominent. So those things are fever, malaise, sweats, fatigue, loss of appetite, weight loss, atypical ischemic signs of symptoms seen with young of the patients having syndrome or symptoms, or extremity ischemia. We talked about how we would specifically state what type of a hemorrhage is out there. So if we have a petechiae, then it's those smaller ones. Purpura are widespread, so it's not just one, then it's showing up. And then ecchymosis, yeah. Okay. Levato reticularis, reddish, purplish, reticular of a pattern of the skin. This will be before some of the ulcer formation. Swollen venules from obstruction of the capillaries will show these things out there. There's that of the purpura, multiplex, aka of a foot drop, of a west drop, right? So that's that special examination that y'all know good is of the clonus, right? So up, and then if it's going to keep going, then we've got some of that stuff going on. So that was all of those first 15 slide-ish. Now let's get into the good stuff. GCA, okay? Most common type of vesiculitis in adults. 1 in 500 in people over 50. So it's greater than 50 years old. GCA, most common. Female predominance is 2 to 3, up to 1. Preferentially affects the external branches of the carotid artery. So it goes up. 50% of GCA patients will also have the polymyalgia rheumatica. So PMR is that aching and stiffness of the shoulders, neck, and hip girdle area. Classic presentation. So you are in an ER or you're in some type of a clinic to where you have a patient present with a new headache, jaw claudication, so that's that pain that worsens if they are chewing. Scalp tenderness, so up one of temporal artery, it hurts. Visual symptoms, and that's going to be an important aspect here, and we're going to talk about it. And then the polymyalgia rheumatica. 25% of the patients can also have some type of aortic involvement. Basically, that's resulting because of asymmetrical arm pulses. Like ANA, ESR is very high, so 90% will have an ESR that is over 50. So those are all of the clinical presentations out there. There's those criteria, which is exactly what we just spoke about. So age, new headache, temporal artery abnormality, ESR, and abdominal artery biopsy. You only need 3 of the 5 to get this diagnosed out there. If we're going to do a biopsy of the temporal artery, it needs to be done within 2 weeks of the steroids before biopsy results will be altered. Consider second biopsy if the clinical suspicion is high after an initial negative. So if we're doing that, after 2 weeks and it's negative, then we would want to do it again. Prompt initiation of high-dose corticosteroids. I told you earlier that one of the diagnostic or one of the presentation that makes us think about GCA is vision loss. Vision loss is going to make us think about what we're going to do. So if this patient, who we think could have of a GCA, if they have experienced transient vision loss for a few hours, we're going to admit those, and they're going to get a high dose intravenous methylprednisolone. And then after that, we will transition them. But if vision loss is there, we're going to admit and give IV. If they do not have a vision loss, then we're going to give them prednisone and send them away. So vision loss is a big one. Most of these patients require treatment for 1 year. After the first month of treatment, almost all of the patients will have a normal of an ESR. So this is why we need to check the labs and we need to do the biopsies before we get to that 2 weeks of the steroids, because they're going to come back and they're going to look all normal. At this point, the prednisone can begin to be tapered by 10% every week or 2. When the patients reach 10 milligrams, decrements of 1 milligram every 2 or so weeks may reduce the chance of flare. Consideration of additional of low-dose aspirin, 81 milligrams, may reduce chance of associated vision loss or stroke. Do not delay steroid therapy while awaiting temporal artery biopsy. As long as we're doing it before that, then there we go. Methotrexate can be considered, though controversial, so don't use it, okay? So that's all of that GCA. What is the most important part when they are meeting you in an ER or something? That is indicative of what? Vision loss. Medium vessel vasculitis. So that's breaking it down into a beautiful thing that is talking about where it is happening and what could be after it is in there. So we're talking about aorta, arteries, back and forth all the way down to those things. And then it's just going to point you in the right direction depending on where those things are at. So PAN is one of those other things for us to chat about. So the polyarteritis nodosa, breaking it down, that is a necrotizing inflammatory vesiculitis of the medium arteries and muscular arterioles. This thing right here spares venous circulation and of the capillaries. So it's confined to that arterial circulation. They will have some of the subacute constitutional symptoms, including fever, weight loss, malaise. If it is on a lower extremity, as seen in the picture, then they can have foot drop. They can get that postprandial pain. So they eat something and then they have it. Angiogram or biopsy of involved organ required of the diagnosis. Usually we don't do that towards of a lung because we don't want to poke at it. And then the granulomatous inflammation is absent. Epidemiology. Diminished prevalence as former subtypes of PAN have been reclassified as other vesiculotypes. This one right here is rare. It is equal between of gender. May be associated with hepatitis B, hepatitis C infections, Treatment and vaccination of Hep B is reducing incidence further, so we're going to push those out there. Clinical characteristics, usually an insidious onset of constitutional complaints. So like we said before, fever, weight loss, arthralgias over weeks to month. If that is Hep B associated, that usually occurs within 6 months of them having that. Less common since starting vaccination, so get that stuff done. Peripheral neuropathy, so we talked about the weakness. We also talked about the foot, wrist drop. Those things are frequent. If this is associated with PAN, it's likely that they could have some of that. Abdominal pain may be prominent depending on mesenteric vessel involvement. Secondary hypertension from renal artery involvement. So dermatological findings, that is of the palpable purpura, livedo reticularis, skin ulcers, digital gangrene, and like before, pulmonary involvement is absent. That's part of the reason why we don't do the biopsies. Laboratory testing is non-specific, but of course we want to look if it's been 6 months since they had that Hep B. Biopsy, we're going to get in the skin, affective nerves and muscle, characteristic transmural necrosis and homogeneous eosinophilic appearance of the blood vessels wall, and then we'll get into some of that angiography so we can see if it's having some of that microaneurysms. Just like GCA, we're going to start with that prolonged high-dose corticosteroids, but PAN is not admitted. If we're going GCA, we're going to admit and give that IV. We can also use cyclophosphamide if they have some refractory to of those glucocorticoids, or who have serious involvement in major organs such as the GI and yada yada. Prognosis wise, this is poor without treatment. So a 5-year survival is approximately about 10%. Advanced mononeuritis, multiplex, can be severely disabling problem from which recuperation is measured in months or years. Overall, good prognosis if we are treating that. So that same of a 5-year, if we're treating it, then 90 or 60 up to 90%. Most patients achieve remission with steroids, and that cyclophosphamide relapse is uncommon, so let's treat it right and then we are good to go. I gave you those 2 lectures in about 37 minutes. Out of the 9, 3 of those questions I just gave you. Okay? All right. Y'all want a break or should I press on? Break? Press. Okay.
Oh, break.
If you would like a break, then you can get up and you can run off. So this right here, this is going to have some of the 9 questions too. All right. Biopsy and suture techniques. Again, dermatology is not a surgery of a course, but this is going to point out if we could do some type of a punch, a shave, excise, why and when those are out there. So we're going to talk about this, and then when we do that derm and surgery lab, y'all are going to get all of the pig's feet and get to have fun. They are. All right. So with these surgery stuff, we have it either incisional or excisional. So incisional, that's that only portion of the tumor is removed, whereas excise is take it all. So we need to get everything out. that shows there, right? We don't have to take all of the tumor out. It's more of a diagnosis. But if we think that this is some type of a melanoma, then we have to get it all the way down to the sub-Q. So you can see that's epi, derm, sub-Q. 3 things: shave, punch, excisional. When we do all of these things, except for some of the shaves, we'll be using some anesthesia. So we can use lidocaine, which is a rapid onset, so it'll be there in about the 2 minutes, and that'll last up to 1 to 2 hours. We can use some of the bupivacaine, marcaine, slow onset, so it takes a little bit longer, but it's gonna last much of the time, so 4 to 8 hours. Slow injection decreases of the pain. If we know that it is some type of a vasoconstriction, then we're going to give some of the epi just to make sure. If it's epi, obviously we want to not put epi into the ears, nose, penis, toes, fingers. Okay, so we don't want to use those things because we don't want to take away all of the blood flow. Those things are, not as large as your arm. Once you inject this kind of stuff, then we're going to wait. Instruments, scalpels, needle drivers, skin hooks, sutures. So those are 10, 11, 15 of the blades, and then it's those things that we attach those depending on what size. There's of that shave, right? So we can lift it up, scrape it off, and those are those things that you will see often. We have those holders, so the needle holders that are going to help us, to put the needles in and out. We have those of the forceps that'll, attach with one hand, and then we're going to lift and hold onto some other things with the forceps. We can also have those hooks that just help to push it out of the way. Okay? So now we're going to talk about each of these of the biopsies. So shave biopsy. Purpose is to obtain tissue for diagnostic purposes. It's also used to remove benign surface neoplasms, so we can use it for of that SK, warts, benign appearing nevi. Something important that it's only applicable to a shave biopsy if it is a raised lesion when the full thickness tissue specimen is not necessary, then we can use a shave. So we don't need all of the full thickness, then we can shave. Like everything, we're going to mark that lesion prior to the anesthesia. We're going to insert the needle into the dermis and infiltrate with anesthetic to raise it up. Okay, so you can see that a wheel. Usually we can shave that with a number of a 15 blade. We can use that beautiful DERM blade that we saw in the picture earlier, but you can use that Gillette blue blade. So hold of it parallel to the skin surface and scrape it off. Non-dominant hand for the counter traction and stabilization. So right, you're going to use the left to hold on to it, yada yada. Contraindications. So if we suspect, like I said, that this is some type of a melanoma, then we're not going to shave because we only use shave if the full thickness is not needed. Need to determine thickness of tumor, so Breslow, and degree of invasiveness. What's that? The Clark level staging. That will let us know if we can use it or if we cannot. Advantages. It's performed rapidly, no sutures are needed, assistance is not necessary. It's a clean procedure. Localization of the site, biopsy is not difficult. Wound care is simple and no restrictions of activities during of the healing. Disadvantage, you could get some of the hypopigmentation because it's more of a white skinish up and under. You can also have some type of a scar. That depressed scar may result if the biopsy is done too deeply, then it's there, right? We're injecting, we're infiltrating to cause some of that wheal and take it off. Not for full thickness diagnosis. Again, said that earlier. Shave biopsy for full thickness isn't needed. Again, complications, scar, hypopigmentation, redness, regrowth of incompletely removed lesion, and infection, which is rare, but it can happen. That's what it looks like. So we're applying that infiltration to raise it up as of the wheal, and then we're going to shave it off. Sometimes if it is peduncular, then you could also snip it off with some scissors. So that is shave. Now here is punch. So this one would be used as well as excisional if a full thickness is needed. Most superficial inflammatory and bullous diseases is what we're using it for. Benign and malignant tumors, except for malignant melanomas. Size ranges from 2 to 8 millimeters. So how large or small is that circle of the punch? 2 to 3 millimeters for face and small lesions. Larger typically require at least 1 stitch. So if it's a smaller one, then we don't have to use one, but if it's larger, then we will. And that is what they look like. So you can see some of the smaller ones, that one up there. Again, we always want to have that punch biopsy blades to be larger than what is being chopped off. Anesthesia, just like before, so we're going to infiltrate to feel full depth, wait for 10 minutes. That non-dominant hand will hold tension perpendicular to the relaxed skin tension lines. We want to penetrate completely through the dermis, exposing sub-Q fat. The fat, so as we lift it up and out, then we can see the fat. And then we're going to take those scissors, snip it off. If it's a large one, like before, then we'll have to use a suture, which we're going to talk about in just a little bit. Tissue punch biopsy. That's step by step. You will feel yourself go into the sub-Q, and then you know that you've gone far enough. Contraindications, so an anatomical location. So if there's some type of an artery or of a vein, yeah, let's not do it. Contraindications can also include of the hand, dorsum, face, neck, and of the volar wrist. Again, blood areas. Advantages, well, you're going to get a full specimen, so you're going to get that full thickness. It's better, cosmetic, faster healing, easy to use, convenient, and relatively inexpensive. Diagnostic is that hypertrophic scar. If we're having to use some of the sutures, then they have to come back so that we can see them again. Unless you used of a sub-Q suture and of the steri strips, and you don't need them to come back and discuss that so that they can know that. So that's basically self-absorbed things that it could work with. You can also use the follow-up to inspect wound healing and wound care complications. Complications, it can cause you to have some of an induration, erythema. You can have that hypertrophic scar like we talked about, excessive protruding at skin edges, so you have that dog ears. Bleeding, infection are rare, but they can happen. So there's that circular punch of an oval defect. That's how we, if it has to be of a nail, then you could do of a punch biopsy on those things too, but just clip it and rip it out. That can be there. Excisional biopsy. Indications, you've got some type of a deep inflammatory disease, erythema nodosa. If it is malignant melanoma, or if you have some of the BCC, SCC, then we want to excise it because we want to take all of that out. Preoperative evaluation. So are they allergic to any of the medications? Are they on some type of a aspirin, of an NSAID, of a warfarin, of a Coumadin? Are they having those things that would help or have them bleed? Did they drink or smoke? That could cause some of the bleeding to happen more. Infection with HIV or hepatitis, tendencies towards abnormal wound healing. So in the past, have they had of a keloid? Have they have of a hypertrophic scarring? Determine relaxed skin tension lines or natural wrinkle lines of the skin. So we want to place incision to parallel or fit within those skin lines. Biopsy should include 2 millimeters of margin of the normal skin. So as you draw it out, as you are making it look beautiful, you want to put that marker stuff 2 millimeters outside. Technique, so draw that ellipse with a surgical marking pen. Length should be 3 times the width, so longer is okay, and ends of the ellipse 30 degrees to avoid dog ears, which you can see that on the photos here. So incorrect, incorrect, correct. So it's got that ellipse area. Holding hand, one of your dominant hand, the other one opens it up. You can see some more of the wrongs because that individual didn't know how to cut and suture because it's all of the dog ears. So you can see there, that's of that mole, but that is of the cut, that is of the 2 millimeters out. Longer is better than width. Again, you can see that there. Looks like a beautiful face, like that's an eye, then there's a nose. Wow. So, how are we going to do this? Well, we're going to get some of that anesthesia. We're going to wait 10 minutes and for the vasoconstriction and of the numbness. Hold the scalpel handle perpendicular to the skin, traction with the opposite hand. Use the belly of the blade, so that's that part that just curves. Tip only for the corners of the ellipse. We want to go all the way down to the sub-Q, so we want to get all of the fat. Elevate with the forceps and snip with the scissors or scalpel blade, to go up and under. Closure-wise, 1 or 2 layers of suture. So depending on of the size or of the depth, we have to use down below some of the self-absorbed of the sutures, and then up top we can use those ones that eventually we will clip off, which is exactly what I just spoke about. I didn't read it. Good job. Surgical of the complications. You can have some type of a scar, greater risk on of the chest, the back, and of the shoulder. We could have infection, usually not, because we're going to also cover them with some of the topical Bactroban or some other things out there. You can have excessive bleeding, so you would need some of the hemostasis to prevent post-op bleeding and or hematoma formation. They can also have some of that nerve damage, especially if we're doing this on the head and of the neck. We will have some of the closures. So simple interrupted, so that's slight eversion, no tension relief, adjust to irregularities and wound edges. Subcuticular relieves tension of the skin surfaces. So that's what they look like. These are those the buried the dermal sutures. So it's putting them together of the dermis, and then we'll do it up top with those other ones. We can also have of the running. So rapid closure for well approx edges under the little tension, so it's locked or unlocked. So we can use of a horizontal mattress, a vertical mattress. We can do those things out there. Post-op wound care. So in the first 48 hours, we want to go ahead and use these things to prevent some of the bad stuff of that wound. This contributes to healing process by partially immobilizing the wound. Best results are to keep it moist and covered. And of course, like always, we want to avoid sunlight and wound during that healing. You're going to provide them of a wound care sheet to let them know. Keep your damn bandage on for 24 hours and keep the area dry. After bandage removal, cleanse the wound with soap and water morning and night. Apply topical antibacterial ointment twice daily and then cover it up. Do not expose wound to pools, hot tubs, salt water, or lakes. Don't go swimming. More of the other things of the Tylenol is safe, but avoid aspirin, NSAID, alcoholic beverages for 1 week after the surgery. If the bleeding occurs, we want to apply firm pressure with your hand over the dressing. Keep pressure for up to 20 minutes. If you cannot control the bleeding, call our office or the provider on call. If you cannot reach someone, then go to the ER. More things to tell the patient. Infections generally do not occur until 3 to 5 days after surgery. If you are having increasing pain, redness, pus, several days, call us. Please return as requested for wound recheck and suture removal. Warn physical active patients to limit activity. The physician site is mobile area, arm or back, and then we want to prevent hypertrophic and scar. Now I know that everyone in here, well not everyone because I see some faces, we're looking at P's. Well, this is a slide that you could look up here because this is definitely something going to see. So this is us picking what we're going to be using for sutures. So you can see that it breaks it down into, is this on of the scalp, is the eyelid, is the face, is the neck, or is the trunk? So you will be told probably where it's at. Then we will know if we're going to do some of the deep stuff that'll be self-absorbed. For that one, we are going to use these things here. If we do deep layers, then we're going to have to do some of the stuff up top. So we would have to use of the skin layer. Okay? What are we going to use? So let's say that it's of the scalp. Then I can use up 2, 3, 4, and it's going to be vicryl. If it was deep, then I would have to do skin also. So I would use 4 to 5. and it can be nylon of the Proline or just staple it up, okay? You will have that as a question, I promise. Okay, these are some of those things. So that is of the simple interrupted. That is of the staples. Simple interrupted, that closes that up. Talked about how we can do of a horizontal mattress, which that'll be Grande, who will actually show y'all those things more. So that's what of a horizontal mattress looks like. That is what of a vertical mattress looks like. And that is it. That is done with all of the DERM and room lectures. On Monday, I will